Well, here's the guts of what I want you to know. When we look at the entire cohort, C4A is right around 10,000. This is not too different from what I showed you before, was 10,000 for post-Lyme. We sorted by ECM positive and ECM negative. Interestingly, ECM negatives had higher C4A than any other cohort. I'm not quite sure why that is. We can speculate. People who had Western blot IgG positive, that means 5 or more bands to satisfy the CDC. The IgG negative was higher than IgG positive. Similarly, when we broke out IgM positive versus IgM negative, there was some discrepancy between the two numbers. There actually is not much difference. The biggest discrepancy here, this one is statistically significant and this one is close. And remember, I'm using 0.001 as my cutoff for significance. HLA susceptibility didn't really make a difference if you get Lyme, but it makes a big difference if you stay with Lyme. Here we have antibiotics, treatment for 3 weeks. Here we see not much difference in all these groups except for the HLA negative people. If you're HLA negative, it means you're not 4.3.53, 11.3.52b, 15.6.51, 16.5.51, or 14.5.52b. If you don't have one of those 5, you're HLA negative, and these people did very well. Now, what we did here is push them on cholestyramine actose anyhow. And this was the idea of the study. And we took HLA negative people and we further dropped their HLA to lowest that there was. But C4A after actose and cholestyramine, we dropped all of these down under 2,800. So if all we say, did we cure the C4A in these people? The answer is yes. Did antibiotics alone cure them? No. I didn't pursue antibiotics for 6 months and a year. I didn't need to. And as one of the Amish people told me who came down, that's a highly inbred genetic group. They have about 6 haplotypes in them, and 15.6.51 is tremendously overrepresented. You see a lot of Lyme in the Amish community. And the fellow says, well, I went to see this doctor who gave me antibiotics. I wasn't any better. I went back. He said, you need more antibiotics. I wasn't any better. I went back again. He said, you need more antibiotics. And he says, why? It didn't work the first 2 times you gave it to me. Good question. C3A. Here we have numbers that are not over 940 to get started, and this really is reflecting the fact that I'm not seeing these people within the first 4 to 5 days of their illness. We talked about C3A in some detail yesterday, but what we had in the overall group is a nice reduction of C3A with antibiotics. You know, we are clearing some organisms from circulation just looking at this mean, but we further reduce it after treatment with actose and cholestyramine. So that while C3A elevation is not enough to say high C3A means Lyme, we do see a fall in C3A even though the levels didn't go higher to start. TGF Beta 1 is showing us more of the same. Here we don't find the difference between ECM positive and negative. We don't find the IgG negative group showing much difference. And it's pretty uniform in all these people. But again, look at HLA negative, non-susceptible people after antibiotics. We're dropping their TGF Beta 1, getting close to 2,300. And when we lower it all the way down to 2,141. Now, there are some cohorts here where TGF Beta 1 is not corrected. Overall, we still are a bit too high. Then we'd want 2,380 to be our cutoff, and you can see we still have a way to go. Now, the question that I have looking at these data is how much longer should I be continuing my biotoxin stuff? Because this does not include use of losartan, does not include use of VIP. I tend to ignore levels of TGF Beta 1 after treatment as long as they're under 5,000. And I'm willing to listen to argument saying that that's not a good idea, but I've not seen that much of a big deal with cognitive issues, neurologic issues, liver issues, kidney issues, or lung issues, or autoimmune problems with TGF beta 1 less than 5,000. Having said that, if you have a level that's too high, you can lower it.